Welcome to Race Dental Webinar Series, episode 21. Believe it or not, we are well into it. We've had a lot of good speakers and a lot of good content. Only yesterday was I talking to a clinician who was telling me they were looking forward to Professor Michael Stubbs joining us again today. There's no doubt he's the most requested of all our clinicians and webinar speakers, so we're super fortunate to have Professor Stubbs back with us today. Now, as dental professionals, obviously it's our responsibility to look forward and to look after each of our patients. What happens when those patients come to you and they've diagnosed with they're simply not a dental problem? And how much responsibility should we put on our shoulders, or your shoulders as a dental professional, to look after those patients? When do we know that, or when can we find out? How do we know that maybe what we have diagnosed can't help them, or how do we diagnose what those problems may be? So today we've got participants from all over the place. Joining us for today from Australia, New Zealand, Malaysia, Singapore, the US and India for our episode series number 21, diagnosing non-dental causes for facial pain. So I won't delay any further. I'll hand it straight over to Professor Stubbs. Thank you, Michael.
Thank you, Matt. And thanks everybody for joining us. Now I'm just going to do a share screen here. Here we go. So I think, one of the things as dentists is, I hate to say it, but one of the biggest motivators for patients coming to see you as a health professional is pain. And obviously, we know that there's a lot of colleagues that operate practices based on aesthetics and so on, but in a fundamental way, pain is a big motivator for people to seek dental treatment. And I'd just like to share with you, as a specialist in my own field, some scenarios that you might like to consider when you start to appreciate the pain that the patient's presenting with is no longer what you deem as dental in origin. Now, pain, this guy looks obviously clearly stressed. He's not exactly happy. It's not because he's received a fee. It's actually him demonstrating that he is experiencing a lot of pain. And I think the nice thing to say to you, all of you, is that one of the best things we do as dentists is we are diagnosticians. And many colleagues realise that when they start to hear the story of somebody's pain history, you start to, in your own mind, you start to gel out, don't you? Is this making sense? Is this dental or is this non-dental? I mean, why does the person have the pain for 10 years? And how come it just affects one side or don't affect both sides, etc.? And I think one of the other things that's really important to say is our knowledge in neuropathic pain has really developed in the last 25 years. So it means that you can have, let's say, for example, pain coming from a region, whether it be any part of the body, even, dare I say, an extraction site. You have a tooth extracted, but the patient still presents with phantom tooth pain. These are not imagined symptoms, these are real. They're real because we understand now that when you take the pulp of a tooth out, that's the nerve, isn't it, of the tooth. How is it that some patients will have persistent pain post-endodontic treatment, called persistent dentoalveolar pain? And it's because, again, there are subtle changes that happen in the nerving in some patients where these symptoms are continually generated despite the fact that the tooth has no longer a pulp or the tooth itself may no longer exist in that region. And I think it's also important to say to you that people don't imagine pain, I mean, it saddens me when I get patients who might come to me and they'll say, I went to my dentist, I told them I had pain, they couldn't find anything, and they said to me it was in my head. Now, we know geographically that is correct, but it's not really perhaps appropriate to say that to your patient. I think the best thing is to say, look, I can't work it out. I don't know why you've got the problem. I suspect it's not the teeth. Perhaps we might just consider getting a second opinion, which is very appropriate. And I think in basic sense too, remember too, folks, that with pain, there's always what we might say the organic and what we say is a psychosocial part. Now, I don't want to get caught up in the terminology, but I think it's really important before we start just to understand why some patients can present, let's imagine, gross caries and draining abscess of a tooth in the mouth, and they'll present to you as if they're not experiencing anything or it's just mild discomfort. And you should get other people who might have a very tiny carious lesion, a little bit of dentinal hypersensitivity, but it's the end of the world. And it's because pain affects people differently based on their previous experiences, and hence the term psychosocial. So we look at the patient as an individual and we say, what can we determine organically, whether it's because we do clinical tests, whether it be, for example, on pulp testing on a tooth, or whether it be, for example, percussion tests, radiographs, and so on. But once you exclude a lot of what appears to be non-organic, in other words, not something you can't attribute a cause to, always think about the fact that neuropathic pain is where you can have pain generated from nerve endings rather than necessarily from the tooth or the gum region, wherever they're experiencing the pain to be. And so here in this image, this is one of my patients actually, but it's basically there to say this patient presented with pain in the temporomandibular joint region, and they also had limited mouth opening. So with an MRI, what this is really doing here is it's showing that there's the condylar head. We can see here the disc is displaced. So we would say in this case, the patient has what we call temporomandibular joint disc displacement without reduction. And so that's the biological part. But of course, you throw in other contexts. The patient's anxious. They don't particularly want to be in your chair, no offense. They actually might be under a lot of stress at work or home. They may have had previously bad experiences at the dentist, for example. You add all those elements into it, and that's the person you're looking at. And you're getting the culmination of all those inputs. And so it's always interesting and wise sometimes not to jump into treatment in the first instance. Get a good history first, and you start to put the pieces of the puzzle together. So enough of the background. So what questions would you ask? I think one of the most important ones I always suggest is ask the question, what's the quality of the pain like? In other words, is it dull or aching? Is it constant? Or is it intermittent? And is it sharp or electric-like? Now, the reason being is we know that if it's, let's say, somebody puts a fluid in their mouth, let's say something cold, and they get instantaneous sharp pain, when they swallow it resolves, it would be a fair call to think it's dental hypersensitivity. On the other hand, if they have nothing in their mouth, but they move their jaw and they get these jabs of pain that's sharp and intense, almost electric-like, you might consider the possibility of trigeminal neuralgia as one of your scenarios. Dull, continuous aching also is particularly common in musculoskeletal pain. So people that have pain in their masseters, pain in the joint, they might have this ongoing constancy of pain. And severity, and I put here the visual analog scale. So what do I mean by that? In basic terms, you say to your patient, if you could tell me a score out of 10 where 0 out of 10 is no pain and 10 out of 10 is the worst pain you can imagine, can you give me some idea of where you're at the moment with your pain scoring? The reason being is you don't hold the patient literally to the number, but it's a guide. I'll give you an example. Someone might say, oh my God, it's 10 out of 10. And you'll say, what relieves the pain? Oh, Panadol. So there's an indication this patient has a low pain threshold. And on the other hand, you say they might say, I've got a score of 5 out of 10, and then you do some treatment on them, and they'll come back and they'll say, oh, it's now 1 out of 10. You use it as a guide to see how you're therapeutically going as well with the treatment, but it gives you some insight into the individual. And always ask the question, obviously, how long have you had the problem? Does this come and go? Is this something you've never had before? Is it something that's lasted a few hours, few days, maybe a week or more? We'd say that's acute. And obviously, if we're talking weeks, months, or dare I say years, we're talking chronic. And does it come and go, as I mentioned, or is it always a constant? Is it one side, both sides of the face, or the jaw, or the mouth? And particularly, I'm always interested in what aggravates the pain. So someone might come to me, for example, I had one this morning, where she actually had, believe it or not, her presenting symptoms were she had paresthesia, tingling in the lower lip. So before she walked in the door, I was thinking in terms of the trigeminal nerve, and I organised a CT scan to have a look at the anatomy to see if there's no compression from any, perhaps a tumour or any abnormality in the course of the pathway of the nerve. Yes, I realise an MRI is even more sophisticated, but a CT scan is a good starting point. But, in the end, the symptoms had resolved when she came to see me, but she had a cracked cusp. So cracked cusps always can be difficult things to determine, and often you'll find when someone says to you, I've got pain in this tooth, and you can't establish a diagnosis based on pulp testing and percussion, I always advocate cracked cusp detecting, because it's amazing how Sometimes just doing that, bingo, you get the diagnosis. And, ask the question, how do you find the pains aggravated by opening or closing of the mouth when you're yawning? If they say yes, you're starting to realise you're talking about temporomandibular disorder. And the reason I say nasal, ocular, or taste changes, see, if someone says to you, I've got terrible pain and a foul taste in my mouth, you might be thinking an abscess. And I hate to say this, Matt, because you're having lunch at the moment, but pus tastes revolting. So, not that I've personally tried it, but I do know that it does, and by all reports. And so if you have nasal symptoms, does the patient have sinusitis? Is that a suggestion that might be the reason why they've got upper tooth pain rather than necessarily from the teeth? And saliva flow issues might be something where someone may have a dry mouth. They may actually find that during the course of a meal, they suddenly get swelling. Again, it gives you some insight into what to look for even before you examine the patient. And always ask the question about ear symptoms too, because I find we know that patients who get pain in the ear is commonly going to come from other than ear problems. So usually those patients would say, I've been to the doctor, I always have a blocked ear, I get pain in my ear, and they've told me it's nothing wrong with my ear. Palpate the TMJ, because usually that's the culprit. But also recognise too that sometimes you can get neck pain, in particularly the cervical nerves of C2, C3, which can refer up to the ear as well. So someone might have a stiff neck. When they turn their head, they have a lot of pain when they turn their head. Well, clearly that's not dental. So again, it's just asking the right questions, gives you the right answers. So I'll give you some examples of non-dental ones. These are common things, okay? And I realise most of you perhaps watching this probably say, yeah, we already know this. But it's interesting to have a conversation. So if someone comes to you with pain on both sides of their face and they attribute it to teeth, think TMD and think sinusitis as your first two scenarios, non-dental. And so TMD, as you know, temporomandibular disorder, I gave a talk last year on that in particular, but we know that usually you'll find the pains worsen when the patient chews their food. And you can palpate the masseters. And one of the reasons is because masseter pain can often refer into the dentoalveolar region. So, you get these cases that you hear about where someone may go to the dentist and the colleague's not sure. It's one of these molar teeth. I don't know which one it is. So I'll take the filling out and have a look in the tooth. Now, my question to you would be, well, what are you looking for? A crack, or you're looking for caries that you haven't detected on the radiograph? But it might be that you do the restoration and then the patient comes back the following week, you do the next one, and then you do the next one, and it should start to gel, and in fact it's probably not the teeth that's the culprit. And also consider in these cases, particularly if you palpate and they get pain, I always suggest put them on diazepam, 5 milligrams, even for 3 or 5 nights. It's a simple medication, short-term use, and it will seriously demonstrate if, in fact, it's TMD or masseter pain versus tooth pain. Because, as you know, if it was tooth pain, the patient might seem very relaxed with the diazepam benefit, but it's not going to change the pain experience. And so I also recommend a jaw exercise where I get the patient to put the tip of their tongue on the nasopalatine papilla behind the central incisors and do a very slow, gentle stretch, hold, count to 22, and then relax, based on the Roccabardo technique, like that. That's the only time I'm doing that demo. But, it's actually a really simple thing to consider. So don't rule that out, is where I'm coming from. And sinus pain. Look, this time of year, especially in spring as well, people get hay fever. People get, congestion. And sometimes you'll say to a patient, tell me a bit about the pain. Is it worse than when you bend over or lie down? Now, if someone says to you, for example, I go to bed at night, I wake up during the night, I've got to get up and move around to get some pain relief. One of the things you think about is sinusitis. Because of the irritation in the membranes lining the sinus cavities, you get aggravation of the pain, and therefore the teeth, remember, are innervated by the same branches of the superior alveolar branch, whether it be posterior, middle, or anterior, as is the sinus cavities itself. And so the brain will defer to the teeth rather than necessarily from the sinus cavities. But you also think if someone says to you, I go to bed at night and I wake up and I've got a lot of pain, think neck problems too. Because sometimes osteoarthritic pain in the neck can often cause pain as well. But usually these people present with suboccipital headache And they might say something like they get up, move around, or they've got a stiff neck. But sinus pain is really easy to diagnose. And so in this case, you can see rather dramatically, we've got a lot of inflammation. She's pressing on her temples to get some relief, which doesn't do much, but I'm sure she feels better because she's actually got the frontal sinus, the ethmoids behind the nose, and the maxillary antra are inflamed. And here's a great one because this is the gold standard to make the diagnosis, in my view anyway, of sinusitis. It's a CT scan. And have a look at the image on the left. You can see where the little star is. You can see here you've got a clear space of the maxillary antra. There's the tooth roots here. You can see some thickening on the left side, but on the right side of this image, complete obliteration. There's no evidence of any spacing. And so someone who has sinusitis, that's the kind of thing you'd look for, complete obliteration of the sinuses, or at least 3/4 obliteration anyway, because of the mucus, because of the inflammatory changes. So when that person moves their head, they often get exacerbation of pain. They can get pressure around the eye, ear pain, and of course in the teeth themselves. And also remember too, folks, particularly if you see something like this where it's quite intense, radio opaque, check the vitality of the teeth, because remember too, sometimes the molar teeth, especially non-vital, can seep pus into the antrum, and so you can get antral sinusitis based on infection from the tooth. And when we look at this in cross section here, we can again see quite easily the obliteration through the sinusitis of the maxillary antra as well. And in this one I put in there, you can see the thickening of the lining. So again, think about referral of pain. And so the reason for the interaction with the experience of tooth pain is because the innervation of the sinus cavity is also the teeth, nerves that supply the teeth. So the brain defers to the teeth structures. And we can classify sinusitis as either acute or chronic. I think having subacute is probably very academic. Acute means less than 4 weeks, obviously chronic more than 12 weeks. And it's usually described as a dull, aching, and often bilateral, but can be unilateral. And as I said earlier, cold or chewing or percussion of the teeth, back teeth, really stimulates the pain. And obviously they're relieved by antihistamine or decongestant drugs. So sometimes in those cases where you're not sure, and clearly you might say, well, look, I can't refer this patient off for a CAT scan. What I would suggest you do, other than dental assessment, OPGs love them. They're basic imaging when it comes to looking at sinuses, but they're very useful. So you're ruling out dental disease. You're also having a look at the anatomy of the region. But also, if the patient is able to take a decongestant, making sure that they are able to take it. The ones with the pseudoephedrine we all know are the best, but they're hard to get. You have to write a script. But the point is, in 1 or 2 days, patient will tell you straight up if they feel better or not. And again, if they do, it's because they had sinus symptoms. Yes, you might get lucky. They might blow their nose a few times while they're in the dental chair, and that might set the light bulbs glowing and think, yeah, I reckon it's sinus. But sometimes you don't even get that lucky. So that's what I would advocate. If particularly we talk about people who have pain on both sides, not necessarily always the same time, but they might present with left side 1 week and then the next side's the right side. That kind of interchange is actually quite useful to think about. When we talk about unilateral pain, I've just thrown in a couple of really interesting ones. And again, some of these very uncommon, some of them probably a little bit more common than we'd like, but these are some suggestions for you, okay? So trigeminal neuralgia is really called tic de la rue, which is where the name comes from, the tic, because patients would squint their face when the pain came on, is literally like that patient getting an electric shock. And whatever branch of the nerve is affected is where they experience the pain. It's called a dermatome. So, for instance, you've got to remember that sometimes some patients might come in holding their face. And one of the tricks you'll know if it's likely to be trigeminal neuralgia is you'll go to touch their face and they'll move their head away. And they'll also say things like, I often ask them, do you get pain when, in the case of men, if you shave or if you're washing your face? Does that aggravate the pain? Because, again, we know it's not going to be dental, is it? It's going to be something more sensory, more superficial with the teeth. And the other thing that's important too is the classic trigeminal neuralgia typically is where the patient will demonstrate pain, often for no reason, but certainly if they move their jaw, they talk, they speak, clench their teeth, bang, they get these electric shocks, and it's very debilitating. And often you'll find a patient can have the maxillary and the mandibular division in the one go. So in other words, it might be quite regionalised, but it might, as in the third division or the second division of the trigeminal nerve or the first division. But usually you'll find some patients can present with maxillary and mandibular divisions involved at the same time. And the pain tends to come right up to the midline. It doesn't cross over. So these are simple things. And 50% idiopathic, it just means we don't know why half patients get trigeminal neuralgia. Yes, there are some diseases. We know about multiple sclerosis. Clearly, we know about an acoustic neuroma, which is a schwannoma. For those of you who are very into pathology, based on the base of the pons, where the trigeminal nerve exits to start to branch and divide into the supply in the face. I only ever had one patient my whole career who actually had the motor nerve, the trigeminal nerve, involved, and it was incredible. The patient would actually open their mouth and it would just swing like loose, because it would automatically fire up the medial pterygoid muscles. So the thing is, most times with trigeminal neuralgia, the patient will say they'll actually stop dead when there's talking. They can't go on. The pain is the worst they've ever experienced. And friendly advice, they'll tell you if they go to casualty, they'll give an endone or morphine-based drugs and it doesn't do anything. And usually in those cases, always think, in my view anyway, trigeminal neuralgia is one of your scenarios. And on this left side here, this is just a diagram to show this, the superior cerebellar artery being in close approximation to the Caesarean ganglion, which, as you know, is the trigeminal ganglion. Not every person needs microvascular decompression, which is where they separate the ganglion from the artery or blood vessel. That's close approximation. But for some patients, it is actually a game changer, especially those patients who don't respond well to the common drugs we use for neuralgia. As a dentist, you are able to prescribe carbamazepine, Tegretol. My advice to you, if you're going to do that, start the patient off at 100 milligrams morning and night, and every 3 days you can increase it to 200 milligrams morning and night. And if you're the type of individual, let's say in rural Australia or a regional area where you don't have access to your patients getting to the GP often, my advice is you can request a blood test. I always recommend before you start the Tegretol, you check liver function, blood cell count, and you check renal function, called the creatinine plasma levels. It just gives you an idea, for example, if you're prescribing this drug, because it's metabolized by the liver, excreted through the kidneys, that you can be very careful with your dose. I realise for a lot of you watching it might say, nah, I've just sent it to the GP, that's fine too. But carbamazepine, Tegretol being a brand name, as dentists, we can get our patients on the PBS for that. On the right-hand side, again, rarer, in fact, fewer than 10,000 cases I found in Australia on an average year, is multiple sclerosis. Again, any person that has trigeminal neuralgia, my protocol is treat the pain, because that's what they've come to see you for, and then we get them off either through their GP to manage the meds, or certainly a neurologist to do a brain MRI, because you don't want to be treating those cases who have the trigeminal neuralgia and they actually had a tumour that you missed. So yes, you're helping the symptoms, but you're not actually treating the problem. And certainly you want to make sure you've covered all the bases for the patient's well-being. And you'll notice here, brushing teeth can simulate pulpal pain. That's what makes this really hard. You know, you get a patient who says things like, I can't work it out. If I have something hot or cold, sometimes it really hurts, sometimes it doesn't hurt. You look at your teeth, you've ruled out cracked cusps. As I mentioned, never underestimate the role of a cracked cusp in any pain presentation history. And you've ruled out disease based on your imaging and your percussion testing, your pulp vitality testing. In some cases, trigeminal neuralgia can start off like just as tooth pain, and it makes it really hard. And one of the dangers is you don't want to go down the slippery path of saying to yourself or saying to the patient, look, I reckon it's one of 3 teeth. So what about if we start an endo root canal on this one, and we'll see how you go, and then if that doesn't work, we'll do the next one, and then the next one, and then the next one. And I've taken an example from a publication that was, I think it was about 5 years ago, and this just showed a multitude of root canals in relation to the fact that this person had chronic pain. On the right-hand side, this is just a periapical, and again, you can see this patient's had 3 root canals. I have the benefit of hindsight. You know, I get a referral from a colleague who's tried different dental treatments, failed. I automatically know when the patient comes to see me that dental treatment is usually not the cause of the problem. In other words, it's not dental in origin. But I still remember I had a lady who I saw who had 7, 6, 5 and 4 root filled on her lower left mandible region, and she was about to have the canine done when the dentist said, I reckon I might just send her off for a second opinion. So she had trigeminal neuralgia. I put her on Tegretol 100 milligrams BD morning and night, and the pain went. So just always remember that. It's a useful tool. If you're not sure about something, sometimes it's better not to jump in than to actually say, well, look, I'll take the tooth out and we'll see what happens, or I'll commit you to a root canal and we'll see what happens. And I've just put here some of the common ones. One of the problems with carbamazepine or Tegretol, it makes people tired. So that's why you always start off at a low dose. And the maximum dose is 1,200 milligrams, maximum. And these ones I put here, which I appreciate you're very unlikely to prescribe, but if you want to know what they are, gabapentin and pregabalin are also commonly given by the GP. They have their usefulness as well in some cases. And herpes zoster is another interesting one. Shingles. Shingles is actually caused by part of the herpes family virus. It's the varicella zoster virus, the 3rd one. So you've got herpes simplex 1 and 2, cold sores and genital herpes, dare I say, as well, and oral herpes. 3rd one is shingles. And that's the chickenpox virus is your primary expression of the condition. And then in the dermatomes of the branches of the nerves affected by the chickenpox, the virus resides in the ganglion of the affected nerve branches, and every so often it will become active, travel down the nerve ending and affect the region. Hence our understanding of herpes simplex and how you get cold sores in certain spots of the lips or in the mouth. Shingles, one of the key things to pick is number 1, sharp, stabbing, burning pain. People talk about burning pain, you're talking about nerve pain. Number 2, within about 72 hours, you'll start to see the display of vesicles. Now, if it's on the face or it's in the palate, that's the best time to get them on the antiviral. And thirdly, it's very unilateral. So it's only wherever the branch is affected, you'll get the symptoms. So sometimes patients can start by presenting as tooth pain, but within 24 hours, it becomes clearly obvious it's more than tooth pain. You're also involving some of the soft tissues. And this is an example of what shingles can look like on the skin, but can also affect the hard palate. Ramsay-Hunt syndrome I've put in here just simply is where someone gets facial palsy, unilateral involvement of the hard palate, and the blistering and vesiculation in the external auditory meatus. And it's a classic condition that you don't often see, but the patient may initially present with burning pain in the mouth, and then as 24 to 48 to 72 hours goes by, you suddenly start to see the changes that are happening. And the treatment, of course, is antivirals, valcyclovir, famciclovir, and again, treatment is usually done through the patient's GP. How many of you watching this have ever experienced a cluster headache or had a patient with cluster headache? Now, cluster headache is one of those interesting ones. It affects 6 times more men than women. But one of the things about it is it's not just the fact that it's a headache. It's very unilateral, but it also involves what we call the autonomic nervous system. So when someone gets pain, typically it can be the first premolar in the maxillary region. It can be the common tooth, as in the symptoms where it starts. But over a course of time, they start to get the dripping of the eye, what looks like very much the swelling of the eyelids, tearing of the eye, and certainly running of the nose, all unilateral activation of the autonomic nervous system. And you can even get flushing of the skin. So the patient can have like this red flushing pain and, of course, headache, and it wakes them up at night time. And those type of cases, they'll talk about it coming in cycles. So they'll say something like, I get the pain, and then all of a sudden it goes away, and then I'm all right for a day, then I get the pain again, then it goes away. And the cycles can last from anything from 20 minutes up to 3 hours at a time. And the thinking really is that the cluster headache, you might be the first presentation would be presenting tooth pain, but again, with the benefit of asking the right questions, such as I said in the beginning, do you get any ocular symptoms? Do you get a runny nose when you get the pain of the teeth? Those kind of things, and headache, because patients don't always tell you everything because they think what we do is just with the teeth. They don't realise, of course, that the problem they're presenting with may be very relevant to other issues that are occurring, such as the cluster headache, where they get headache as well. And like a migraine, they're generally treated with medication, again, through the benefit of a neurologist. But, you know, if you get those patients that talk about tooth pain first and then it gets worse and worse and it starts to affect their face, ask the question, do you get tearing of the eye, running of the nose, unilaterally, face flushing? Do you wake up at night with a headache? Because cluster headaches typically do wake patients up at night time. And I think another one, just for the purposes of it, is the saliva gland stone. Sometimes you can get pain, aching quality, typically always worse when eating. And of course, if you get the patient that presents with pain in their face and you say, oh, they get swelling in their submandibular region usually, you know the submandibular saliva glands make what we call resting saliva. So it's the submandibular saliva gland that actually dictates ultimately the moisture that we feel in our mouths at rest. Obviously, when you start stimulating it through chewing, you get sublinguals going, parotids going, but it's the submandibular. So if you get a stone, for example, you can get this chronic pain that it radiates under the jawbone. It may actually feel like it's in the tooth. Patient associates it with aggravation when they're chewing, so they blame the teeth. And in this case, you can see here just a simple OPG radiograph highlights here where I put the arrow. You can see the sialolith, the saliva gland stone, and then obviously with the benefit of CT, we can see more detail. Sometimes these stones are huge, and sometimes they sit there and they don't have any problems at all for the patient because the gland can still drain saliva. It's when the duct gets blocked and all of a sudden then you know about it, poof, it starts to really swell. Bad taste in the mouth is generally just because you can get infection, obviously with the blocked duct, and then as a result you can get percolation of the pus into the mouth, which is where the bad taste comes from. And sometimes patients will say things like when they get the pain, they have trouble moving their tongue freely. And again, you might be thinking neurological, but in reality it could just be the fact there's swelling in the floor of the mouth and swelling out here, and consequently the body of the tongue doesn't have as much room to move. And we always think, don't we, as dentists, imagine if this is cancer. Well, obviously I would hope most of you, when you look at your patients and you think in pain, that's the last thing on your mind. But I'll tell you what, sometimes you do get those cases, they exist. Now, this is a good example here where a squamous cell carcinoma of the tongue. But what's interesting too is when you get an ulcer, particularly SCC, squamous cell carcinoma, on the base of the tongue, it often can refer into the lower jaw region and can be an aching or sharp pain, which can mimic trigeminal neuralgia, and it can also mimic tooth pain as well. So again, I realise once you work through the process of elimination and you've ruled out dental causes, if depending on where you practice, you might send them to an oral surgeon, you certainly might send the patient to an oral medicine specialist or even an ear, nose and throat, because they'll do much more sophisticated imaging just to determine the origin of the pain and whether those remote cases that we do sometimes see in oral medicine, certainly as in oral surgery, where the patient's actually got a tongue-based tumour. Again, not common, and I'm not saying it because I'm suggesting that you're going to see one, but isn't it great to be able to pick it? Because you save the patient's life, literally. And there are many stories I know where the dentist has not been sure, they refer them in, we do the scanning, and hey, presto, they've got an SCC in their tongue. So the thing is, this type of history, such as tumours, is where, you know, you do your treatment, even with the medicines. I mentioned Tegretol being one drug, but they don't get better. It doesn't seem to make any difference. And they may also, when you get these cases where they talk about numbness, tingling and numbness, that's a concern as well. I always think pathological. That's for what it's worth. And certainly weight loss and fatigue is a good indicator of the inability for the person to eat, and it may also indicate a neoplastic process happening in the individual. And this was one of my cases just recently where a patient came to me because they had pain around the pericoronal region, as you can see, of the 7. But this change here is highlighted as number 1. was actually a secondary renal carcinoma. Now, go figure that, a secondary that big, but that was the reason. So, you know, the value of an OPG, I can't say enough, is really important. And I often find that any person that comes and sees me for any problem at all, I often do an OPG radiograph. I just find them really invaluable. And in this case, that was just a simple OPG, pick that up. So that was her treatment, obviously, was dealing with the metastasis. And the last one, you'll be pleased to know perhaps, is cardiac pain. Now, again, not common, but how many of you had those cases where a patient presents unilateral mandibular molar pain, dull, aching quality? It varies. Sometimes it's there, sometimes it's not there. You give a block, the pain's still present. Now, that's really important, because when you give a block, inferior alveolar nerve block, and the patient's still got the pain, you know the pain's coming elsewhere. And particularly if you ask the patient, do you get pain in the frontal neck area, sometimes the chest region or the back? Women present differently to men. Men tend to get the full-on chest pain and grab their chest as they have a heart attack. Women can be very subtle, and it can be this aching kind of quality. One of the best ones to determine is it cardiac or not is, does it get aggravated by exercise? It's one of the reasons I'm told why cardiologists like to be on the first or second floor. So if their patients climb the stair and they get to the top and they can hardly breathe, they know they've got a patient's got a cardiovascular functional issue. But it may actually present in the mandible, usually on the left side, but in the throat as well. So again, you know, if you get someone that you've ruled out dental cause, ask the question, does it get aggravated by exercise? And particularly if you're doing a block and the patient's still got the pain, think about referral of pain. And lastly, the treatment for those of you who are interested, obviously anginine is a medication. We wouldn't normally stock anginine in our surgeries, I would think, but patients who have angina usually bring their own. So you give the patient some anginine if they had their own anginine, and obviously refer them to the GP, because the treatment's not going to be dental, is it? It's going to be cardiac management. So on that note, is there any questions that you might like to ask me in regards to some non-dental pain information?
Yeah, Professor, firstly, thank you. That was fantastic. We do have a couple of questions. Firstly, I'd just like to say how great it is to have you simplify your wealth of knowledge in such a way to make it easy for all of us to not only learn from, but for the possibility for each of our clinicians to even save a life. That's it's pretty special stuff. I did notice during your lecture, Professor, we had enormous amounts of latecomers joining us in the tens. So if anyone who missed the start of the lecture wants to know a little bit more about what Professor Stubbs was talking about in regards to what specific questions to ask, feel free to make contact with us at customersupport@racedental.com.au, and we can steer you in the right direction. Alternatively, this will be recorded and on the website in the next day or two. So if you did miss what questions to ask, I think it's real paramount in the success of diagnosing effectively. But a couple of questions, Michael, if I may. I've had patients with tooth pain who say, just take the tooth out, and they're very demanding. I could not find any tooth issues. What would be your response to this? Do you remove the tooth as requested or turn the patient away?
Yeah, I know that's a tough one, because I've been down that path myself. What I would do is, if you ethically feel that it's not caused by the tooth, you have the right to refuse treatment. I know the patient owns the tooth, but it's like someone coming in and saying, look, I've got 2 thumbs and 8 fingers. I want you to chop that one off. You wouldn't, would you? So my advice would be, well, I hope you wouldn't anyway. So I think the thing is, I'd say, look, no, I can't do it. It's not right. Because the problem you have is, if you take the tooth out, as you know, and the patient comes back with the pain and says it's the next one, as the time goes by, all of a sudden, colleagues or the ultimate person that sees the patient will say, well, why did you take the teeth out for? So, I'd stick to your guns if you don't mind me saying, but I understand why you've asked that question, because I have been exactly in that situation as well. And I've sent the patient away because I say, look, I can't do it. I'm sorry.
I guess that's effective duty of care, mate. So thank you. In regards to the salivary gland stone, can a salivary gland stone ever be felt using the fingers on the neck?
If it's big, you probably could, but they'd have to be pretty big.
Through feeling that area?
Well, the problem is, see, the gland itself, the submandibular saliva gland, is a pretty big gland, but the thing is, you'd have to be a pretty big stone so you could palpate. But even if you did, and you could feel something, you'd straight away say, better get an ultrasound at the very least, and or some imaging. I love CT scans. I find that there's no mucking around. You just get straight to the crunch. You get to see the anatomy. But I think it'd have to be pretty big to feel. In the mouth, what you can do is you put your finger under the submental region here, and in the floor of the mouth, and you can palpate the submandibular duct. And sometimes you can actually feel the bumps in there, and that's actually interesting. And sometimes even you get lucky, the patient lifts their tongue up and you can see the stone usually looks quite yellow, and they sit right at the opening of the orifice of the duct. And so depending on how you feel about it, you can put a little bit of local anesthetic and just gently slit the opening up of the duct and squeeze the stone out. And I've done a few of those, and that actually works a treat as well. But obviously some imaging first to get an idea of what you're looking at. But usually you can feel them in the mouth if they're in the duct, but not. It would have to be pretty big, I think, to feel on the skin under the jaw.
Okay, quite interesting. And I guess those sorts of referrals to people like yourself may be best to be flicking stones out. But it does relate to our last question, Michael. Would you recommend an OPG for all your pain cases? Yes.
Now, the reason I say that is because, of course, it's like when we talk about occlusal splints. I'll give you an example, right? I often get colleagues will say to me, oh, yeah, but the latest systematic meta-analysis says that occlusal splints and no occlusal splints, people do well in both. I think, yeah, but the reality is splints actually help patients get better quicker. With an OPG, my view is the more information you have, the better. So my view would be you're screening the patient. Do you know how many times you do an OPG, let's say, because the patient presents with dental pain, and on the opposite side, you might diagnose a cyst. Could be a keratocyst, could be something unusual. So it's very simple, and the radiation they experience is very minimal these days with digital technology. And so I don't mind saying up front, I love OPG radiographs.
Okay, look, there's no doubt you can't manage what you can't measure, Michael, so it's definitely the right way to go. Look, we have exhausted our time for today, Michael. We always appreciate your time. Everyone's always requesting you to come back into the Race Academy, and we do appreciate you giving us that time. The feedback is phenomenal. If anyone has any further questions, feel free to contact customer support at racedental.com.au. Alternatively, the webinar has been recorded and will be up and running in the next couple of days on the Race Dental website under the Race Academy series, as to all Professor Stubbs' previous webinars, so feel free to take advantage of that wealth of knowledge. And also stay tuned, and remember that the oralmedinstitute.com.au has some exciting courses coming up, so please stay tuned on that. We've got some pretty cool stuff coming up. But if there's anything more you wish to know, stay tuned for webinar series number 22. But again, Michael, is there anything you'd wish to leave our listeners with?
No, I think there's nothing wrong. If you can't diagnose the pain, don't feel bad about it. There's nothing wrong, because we all often do feel pressure to have to give an answer to our patients. Sometimes the best thing you can do is not do anything and give it 24 hours. I know that sounds a terribly old-fashioned thing to say, but 24 hours makes all the difference when it comes to diagnosing pain, especially if you're thinking, is it dental, is it not dental? 24 hours makes a huge difference in making the relevant tooth, if it's the tooth problem, appear. If it's the herpes zoster, as I mentioned, you start to see changes. 24 hours.
I appreciate those fine words. So, look, again, Professor Michael Stubbs, thank you for your time. And if anyone needs any more information, racedental.com.au. Thank you all. See you all soon.
Thank you. Bye.